Good evening, everyone. Am I audible to all?
Yes, you are audible.
So, greetings from Kuwait. Thank you, Raghav International Statistical Institute, for giving me this opportunity to share my understanding in incident reporting systems and how it influences the activities of reporting and learning. Okay, I'm sure most of you are familiar with this picture. Okay, it's termed as an iceberg model. It's not something new. I'm sure all of you would have seen it many times in many of the quality trainings and conferences. Well, I've just brought this to refresh our mind because our topic is all about incident reporting and why do we have to report incidents. Well, system thinkers, they often use this model, which is called as the iceberg model. Okay, we know that approximately 90% of this iceberg is underwater. And the width of an iceberg is nearly 30% larger than what you can see on the surface. The 90% of the iceberg that exists underwater is what creates the behavior seen by 10% that exist above the surface. You can apply the same logic to problem solving. You know, we are often alerted to a problem by a surface level event or experience. Creating solutions based on a single event may create a temporary fix, as we all know, but will often result in a repeat of the same problem. And our ultimate goal is, of course, to identify the root causes and the underlying structures or the mental models that triggers problematic events. So the current approach to patient safety is now replacing the blame and shame game with systems thinking. It's a paradigm that acknowledges the human condition, namely humans' error, and concludes that safety depends on creating a system that can anticipate errors and either prevent or catch them before they cause harm. So, universally, a recognition that most errors are made by competent, careful, and caring providers, and preventing these errors often involves embedding the providers in the system that can anticipate glitches and catches them before they do any harm. There are two reasons that data reporting has come to be seen, as an essential for improving safety of care. First, of course, the routine reporting and rigorous investigation of accidents and untoward occurrences has long been a core element of the safety programs in other high-risk industries, like, for example, aviation. And such sectors have generally been more successful than healthcare providers to actually report their risks. So some kind of common sense reasoning within healthcare has been that, we must learn from the things that go wrong. Again, a very familiar picture is the Swiss cheese model. So when we talk about systems thinking, we cannot miss this great Swiss cheese model. And as you can see in the picture, it's self-explanatory, Basically, this picture or the Swiss cheese model was actually introduced by the British psychologist James Reason. So the Swiss cheese model represents organizational accidents, okay, which has been widely embraced as a mental model for system safety. What do we mean by that, basically? Now, it emphasizes that analysis of medical errors basically need to focus on their root causes, not just the blunt error or the smoking gun error, but all the underlying conditions that made an error possible. In complex organizations, a single sharpened error, for example, the person who actually did the error, for example, the wrong medication administration by the nurse, or the surgeon making the incision, that is rarely enough to cause the harm. Instead, such errors must penetrate multiple incomplete layers of protection, which in this picture you can see as a Swiss cheese, to cause a devastating result. So again, when we see or when we talk about Swiss cheese, we need to focus, or the ulterior goal is we need to focus on less on the futile goal of trying to perfect human behavior, and suggest that we put greater effort at shrinking the holes in the Swiss cheese. And these holes are sometimes even referred to as latent errors. I'm sure many of us understand what are active and latent errors. So our effort should be more focused on shrinking the holes to prevent the latent errors. And how do we do that? By creating multiple overlapping layers of protection to decrease the probability that the holes will ever align and allow an error to result in harm. So you can see in the picture how it aligns at one point of time and causes a devastating event. Now, the perspective of quality of care to safety is what this slide shall talk about. Now, I was just thinking during my experiences or during my working time that to an extent, when we talk about quality issues of interest, when we want to improve the quality of care, most of our data can be ascertained through outcome KPIs or process KPIs. For example, if I would want to know the mortality rate in patients with acute myocardial infarction, or a post-operative infection rate, or for example, readmission rates for patients with pneumonia, or any other process measures, like did every patient with myocardial infarction where they indicated a beta blocker, aspirin, something like that. These data does not depend on the direct involvement of the nurses and doctors. Most of it can be collected through chart review or increasingly by tapping into electronic dashboards. Obviously, when a quality leader, when they look into the KPI and when they find a hotspot area in these measures, of course, he or she cannot proceed without interviewing the staff to develop the complete understanding of the process. But collecting the data can often be accomplished without the provider participation. So that's the basic difference between quality of care and patient safety. Now, in most cases, a safety officer will have no way of discovering errors or risky situations without receiving this information from frontline workers. So that's why the institutional incident reporting system is a usual vehicle for tapping this rich vein of experience. Of course, we have other mechanisms like, for example, direct observation or trigger tools. They can also identify some problems, but I believe clinicians are the best repository of the knowledge and wisdom needed to understand safety hazards, near misses, true errors, and which can help to create the system changes to prevent them. Now, usually a reporting system fulfills one or more of the 5 main functions. Now, some of these functions are not always compatible with one another. For example, the use of systems primarily for accountability purpose can disrupt their use in the process of improvement and learning. They may create an environment of fear and apprehension, and which can reduce the willingness to report incidents. The other functions, as you can see on the screen, are response to patients and families, of course, improving communications, and it, of course, is a barometer of risk within the healthcare. And the last but not the least, the most important, incident reporting systems are a foundation for learning and improvement. So today's focus are on the following. We first talk about the various reporting systems. Then we go into the importance of reporting culture. Reporting culture, I will not be going into in depth, just a brief introduction to the topic. System challenges and focusing on how incident reporting can help us in learning. So the first one we talk about is a reporting system. So usually there are 3 approaches. There are a number of ways that reporting systems can contribute to improving safety. Okay, and 3 approaches are what you can see here. One approach involves mandatory reporting to an external entity. Now, this approach is typically employed by states that require reporting by healthcare organizations for purpose of accountability. The second approach is voluntary external confidential reporting. This is basically again to an external group, but it's for the purpose of quality improvement. The first one may not be for a quality improvement, but while sometimes they use it for quality improvement as well. But the second one is mainly for purpose for quality improvement. So there are some medication reporting programs that fall into this category. The third approach is called as a mandatory internal reporting. And this is what usually hospitals, like accredited hospitals like Joint Commission hospitals or sometimes OSHA, They require organizations to keep data internally according to a standardized format and to make the data available even during on-site inspections. And Joint Commission on International Standards also requires this particular incident reporting systems in hospitals to use it for performance improvement purposes. Now, the nature of reporting systems. Of course, we have again three types. Nothing new. Again, I'm just refreshing knowledges. The first one is anonymous reports, are the ones in which there is no identifying information asked of the reporter. Now, such kind of reports do have advantages, but anonymous systems have the disadvantage of preventing necessary follow-up questions from being answered. The second one, in a confidential reporting system, here the identity of the reporter is known, but it's shielded from authorities. Okay, it's not being disclosed, except if it's required for any investigation for misconduct or any other criminal acts. Now, such systems tend to capture more useful data than an anonymous system because the follow-up questions can be asked. And in such a system, reporters must always trust that they are true, that such kind of information are truly confidential. Last is the open reporting systems. Here, everything will be publicly identified, which I believe is not a great approach because it can cause unwanted publicity and blame. Now, some of us term incidents as OVR, occurrence variance reporting, and some of it call us as incident. Is there any difference between the two? Well, reporting comes under two categories: occurrence variance reporting and incident reporting. Now, occurrence variance, the name itself suggests that there is a variation. So what do you mean by occurrence variance? Occurrence is any unexpected patient medical intervention, intensity of care, or healthcare impairment. Or you can say it as events which are not consistent with routine patient care. There's a variation in your practice. And incidence is an event or a happening that causes unanticipated harm to a person. It can be loss or damage to a person or a property. It can be unsafe conditions, hazards, so on. Now, what do we report? What to report? Now, through our system, many systems have different rules, but in general, usually there could be any reporting. It could range from patient identification, as you can see from the screen, a lot, patient care, wrong side procedure, fall, so on and so forth. So we have a variety of events to be reported. And if you're using an electronic incident reporting, you can increase the drop-down list as per how your organization would want to categorize it. Now, a general classification of patient safety incidents, as you can see here, the most simple general classification. Now, patient safety incidents can be classified into three: harmful incident, non-harmful incident, and near miss. Now, for those who do not identify what is near miss and how can a harmful incident be divided into two, let me just explain further. Near miss is an incident that do not reach the patient. Now, if I give you an example, for example, a unit of blood being connected to the wrong patient's IV line, but the error was detected before the transfusion started. So ideally, there was no harm done to the patient. Such incidents are called as near misses, or in other words, close calls. In the later part of my presentation, we can go through why near misses are very important to be reported. Then we have the no harm incident, the one in which an event reached a patient, but there is no major or minor harm resulted from it. Now, for example, the same incident, if the unit of blood was transfused to the wrong patient, but luckily the blood type was compatible, there was no compatibility issues. So there was no harm, but it did reach the patient. So those incidents are called as no harm. And what is harmful? They are those incidents that result in harm to a patient. For example, the same incident, you transfuse the wrong blood to to the wrong patient, and then the patient dies from a hemolytic transfusion reaction. So there goes the harmful incident. Now, with regards to harmful incident, we have something called as adverse event and adverse reaction. Adverse event is something which can be prevented, and adverse reactions are usually non-preventable because they result from a justified action where the correct process was followed for that particular procedure in which the incident occurred. How do we report? Well, a standardized reporting format, either electronic or manual, is needed to define what ought to be reported and how it should be reported. And usually we report what, how, why, and when. What happened, how did it happen, why did it happen, and when did it happen? So we concentrate on these major, information. So it's very important that in hospitals, everyone is educated about how to write an incident report. Now, of course, each dashboard or each electronic incident dashboard will have their own, standards on documenting the required information. Now, I'm just showing you some basic information which should be there in a minimum to capture the right data. Now, with the needs of those organizations, who runs reporting systems throughout, WHO initiated a project in 2011 to address the lack of international co-census for collecting data on patient safety incidents. So they didn't have a uniform, architecture or uniform method. So what happens? It sought to help establish reporting systems that are simple, user-friendly, easily standardized, and integrated into the information technology systems. And in 2005, WHO drafted the guidelines for event reporting and learning systems to propose a minimum common architecture. This led eventually to the formation of minimal information model for incident reporting and learning systems. So from here, you can see some of them are very basic. What do you mean by mitigating factors? Now, mitigating factors are those actions or circumstances that prevent or moderate the progression of an incident towards harming the patient. So are there any mitigating factors in the incident being reported? Are there any contributing factors? Contributing factors are either active failures or latent failures. Okay, for example, communication, equipment issues, supply issues, etc. So this was basically developed on the compilation of work done in collaboration with a few countries. Now, what happens after reporting? I am sure many of you have heard about safety assessment code. Well, there is always a level of subjectivity or always a level of judgment involved in any classification. But however, SAC scoring, which is called a safety assessment code scoring, provides a uniform yardstick from a systems perspective by which to prioritize your actions. Now, why is SAC widely used? I mean, earlier in the slides, I had shown you how to classify incidents. Of course, we can classify incidents generally like what we saw before: harmful, near miss, and non-harmful. But then what happens is the use of SAC, if you apply it at the start of the process, we can reserve our precious resources, particularly time, which quality management staff usually faces, so that you can apply your time where they have the greatest opportunity to improve the level of safety from a systems perspective. SAC score is also of value for incidents that do not actually result, okay, and can also concentrate on near misses. This is a valuable feature since close calls generally occur far more frequently than actual adverse events, and they provide an opportunity to improve the system without having the experience to actual untoward event. Now, how does SAC score work? Basically, safety assessment code is a numerical score that rates the incidents. Okay, it's based on severity consequence of that incident and the likelihood of recurrence. So as you can see from the screen, severity is divided into 4 categories: catastrophic, major, moderate, and minor. And the definitions of these categories are usually being referred from the OSHA and JCO guidelines. Again, when you assess the severity of the event, okay, we always have to assess the severity from a potential risk standpoint. That is the perspective we should be applying this. That is, one should consider the most likely worst case outcome from a systems standpoint. Now, let me give an example to understand this further. Imagine you entered a patient's room before they were able to complete a lethal suicide attempt. Okay, the event would be classified as from the risk standpoint as a catastrophic risk from a potential risk perspective. Why? You would say suicide did not happen. Why should I term it as a catastrophic risk? It is. If you wouldn't have stopped, that is the worst outcome it could have happened. Again, probability, now that's a severity risk. Then you give the score for probability. Probability is divided into 3 categories: high, medium, and low. So these categories are also most subjective. However, whenever you score for probability, you should apply to the organization you work. For example, committing a suicide probability might be very low in a clinic, but it must be very high in a psychiatric hospital. So the probability depends on the organization you work. Again, it must be remembered that SAC score is just a tool with which we can consistently prioritize the activities that are associated with any incident. Okay, it provides a criteria to determine which action is required at a minimum, but in no way it intends or in no way it prevents any quality management professional or a risk management professional from assigning a higher level of priority. For example, if you have a SAC score which is giving you a lower priority to work now, but from your experience, you know that this is something which you need to attend immediately, you should go ahead. So there is no substitute for good judgment. So we have identified where to start. Okay, now the next step is you trigger the investigation. Now, how do you trigger the investigation? Now, imagine you have a serious clinical incident that occurred and you have a high SAC score and you are supposed to attend to it immediately. I'm not talking about sentinel events. I'm talking about the highest SAC score you can get, because sentinel events usually have a different approach of investigation. So, of course, you notify the senior members of staff who have been trained to carry out the investigation. You establish the circumstances as they initially appear and complete an initial summary. Decide which part of the process of care requires investigation. You prepare an outline chronology of all the events, and you identify any obvious care management problems. Of course, without structured interview of staff, you will not get all the information. So revisit the sequence of events and ask questions about it. Ask questions about each care management problems identified at the initial stage. It will be helpful if you can use a framework to ask supplementary questions. Once the investigator has identified the various contributory factors or various other factors, a distinction needs to be drawn between specific contributory and general contributory factors. For instance, for example, a failure of communication between a doctor and nurse may have contributed to some problem. If this is an isolated occurrence, then it is a specific contributory factor with no more general implications. If, on the other hand, the problem is quite common, okay, then you should take it as a general contributory factor as well. List the causes of care management problems, recommend for preventing recurrences. After that, you submit the report to the clinicians, management, implement the actions, and monitor the progress. So this is usually the method what we follow for any investigations. Part of the incident investigation is also to identify or investigate on human factor prevalence on any incident. I'm not sure how many of you are aware about this particular tree, which is called as incident decision tree. Now, David Marks states that actually no organization can afford to offer a completely blame-free system in which any conduct can be reported with impunity. Okay, because some actions warrant disciplinary and enforcement actions. Now, the most important point, what we need to understand it's the balancing of the need to learn from our mistakes and the need to take disciplinary action. That is what we need to address, this balancing act. Now, incident decision tree is based on that algorithm for dealing with staff involved in safety errors in organization. It's also called as culpability tree. Incident decision tree can also be called as culpability tree. Now here, if you go into detail, there are many articles, there are many, references talking in detail about how to work on this, how to use this principle while you actually investigate incidents. Here we actually do different kinds of tests. The first one you can call it as a deliberate harm test. The deliberate harm test is helping to identify the earliest possible stages, where if the harm was intended or not. Now, usually such test is being asked to consider whether this individual's action were as intended, whether the outcome was also as intended. In the majority of cases, the actions will always be as intended, but the outcome will not. But such actions are usually disciplinary in action. Usually the outcome will be disciplinary. Suppose you clear the deliberate harm test, then the next test is called as incapacity test. Usually this is being undergone to see if this individual has some substance abuse issue or had some health issues. And usually the manager is asked to consider whether the employee was aware of their condition at that time, or whether they realized that such a condition, what are the implications of this condition? And did they take proper safeguards to protect the patient? So such questions are being asked during incapacity test. And then we have something called as a foresight test. Now we clear the first 2 points, which is the deliberate harm test as well as the incapacity test. The next test is foresight test. Here, if the intent to harm and incapacity have been discounted, the foresight test examines whether protocols and safe working practices were adhered to. Now, we all have policies and procedures in hospitals, right? So such findings indicate the majority of patient safety incidents always involves protocol violations, mostly. So basically, it asks the manager to consider whether the incident arose because there was no protocol, or because there was no safe procedure, or was the protocol poor, or were there conflicting protocols, or were good protocols there but misapplied, or were they just violated. So there are a lot of options you look into this particular foresight test. And the last one is called as a substitution test. If you clear the first 3, then you do something called a substitution test. That is, it helps to assess how a peer would, deal with the same situation. So this can show us if there are any deficiencies in training, experience, supervision, etc. So it's actually a long, tedious process, but it helps us a lot to actually get information about human factors. Another investigation is called as RCA2, which is the root cause analysis and actions. Now, root cause analysis are usually done as per Joint Commission standards for sentinel events, but many organizations use root cause analysis for not just sentinel events, they do for to detect process issues, any process issues. So the technique basically involves a deliberate, comprehensive dissection of an error and laying all the relevant facts and searching for all the underlying root causes. And such investigations are never satisfied by explanations such as the doctor pulled the wrong chart or the pharmacist stocked the wrong medicine. No, we don't stop there. We have to identify what we can improve in the system. It identifies various vulnerabilities that can be eliminated or mitigated. And some have suggested that the term root cause analysis is also misleading, because we have learned from the Swiss cheese model that most of the adverse event and errors have multiple holes in the cheese. So there is a lot of discussions about why is it called root cause when there can be many causes. So that finishes the first part of us. of the focus for today. The second is the importance of reporting. Now, this figure we had seen when I started the presentation. Now, let's go a little more depth into it. Now, what did that iceberg mean is now more clearer for you. Now, this figure with informations, okay? The main barriers, what I believe, to learning is a situation when an organization actually neglects the iceberg, which is beneath the water. That is when they neglect the potential lessons from lesser severe incidents, which could have escalated into major accidents. And these organizations only learn when a major accident actually happens. This is inherently an unstable approach, which is likely to lead to overall high risks. Now, as you can see here, I have shown two graphs. The first graph shows how is the risk in an organization when they actually give time and effort to low risk incidents, and when an organization only gives time for high risk incidents. So if you look in the top graph, if the only changes an organization is making, if you only make a change, okay, if you only make a change, or if you only make a change from learning from major accidents rather than the broad range of all other events, this will typically lead to large disruptive changes. So you can see here, you might do major changes, you might spend a lot of money buying new equipments, or actually you might even do a lot of costly procedures because you want to reduce the risk. But then you see what happens. Over the long term, this memory of these low frequency events will be lost because there's no more reporting. So they report only when there's major, and they do a lot of actions, and then there's no more reporting. So the memory of these low frequency events will be lost, and the risk is likely to increase effectively unnoticed as the warning signals offered by incidents are not being effectively processed. But if you see the graph below, there is multiple opportunity for learning and changing stability and efficiency when you learn from incidents and near misses. Thus, adopting a learning from major accidents will lead ultimately to an increased frequency of major events, etc. And an efficient low frequency incident process will make use of the multiple opportunities of learning, leading to a lower risk. I hope this picture actually reflects what we can learn, or what is the use of an incident reporting system, or how we should see incident reporting system as. Like we all know, incidents are not something in themselves. They are symptoms of a larger problem. And they will keep on sneaking on healthcare providers from all the directions. Instead of targeting the systems, it seems better in the long term to target the cause of the disease. It's just like treating a patient. We're treating a problem. So that is to have healthcare providers learn how to cope with the infinite variability of safety issues by learning how to analyze this and how to devise corrective actions. So we need the care providers, we need their involvement. The next focus is on reporting culture. When it comes to safety culture, everyone seems to have an opinion. Okay, so you can see from the screen what I have mentioned basically. So with many complex matters in life, the truth lies somewhere between the commonly polarized viewpoints. And underreporting programs have the following reasons and why people don't report usually. And I think my next speaker will talk more about the culture. The balancing act is what we need to understand. That's the most trickiest one. In our zeal to hold the habitual rule breaker or disruptive caregiver appropriately, we need to guard against creating overly punitive actions. And when we identify care providers who harm patients, we need to be compassionate and help them. So if there are bad apples, we need to tolerate them, and that is just another systems problem. So accountability and reporting culture is what is called as just culture. And usually these are the following actions we take to manage behaviors. System challenges. Well, a well-organized IR system can yield important insights, but can also waste substantial resources. So it must be approached in a very tactful manner. So these are the bitter facts of incident reporting management system. You have a volume of data, you have a lot of reporting errors, which takes time. Sometimes you don't have sufficient time and resources to actually do the analysis, and a lot of diversity in the stakeholders as well. And actually, does voluntary reporting give the rates of errors and harm of an organization? No, it can never. Because if you say that you have a high reporting, some organizations see it as, okay, you have a good culture. Some of them say that, okay, I have low reporting, I don't have enough incidents. So there's a lot of interpretation issues, and a lot of resources and time is being used for incident reporting analysis. The last one, which is the most important, is the focusing on learning. Now, the major issue today is not with incident reporting, but taking actions on the reported data to truly affect any change. The most important capability of patient safety incident reporting and learning system must surely be its effectiveness in recording future harm. So the whole question of how learning takes place through the scrutiny and analysis of incidents or through the investigation has been researched. So you can see how it is being actually used for learning. Learning should be seen always as a participatory process that engages a wide range of people. So you can see what are the various conditions to active learning. When you say collaborative maturity in an individual, it means you are a thinking process person continuously. When you say role clarity, they know specifically what's expected from them. Since I do not have much time, can I have at least 5 more minutes? I just have 3 more slides.
Sure, ma'am. Please go ahead.
So a 2016 article contrasted event reporting in healthcare with event reporting in other high-risk industries, pointing out that, so much of emphasis is being done on collecting reports instead of learning from incidents. So there is one Dutch healthcare inspectorate, okay, example of how their focus, how did they learn from sentinel events is what I want to show next. So this is the example of the hospital, okay. So this Dutch health inspectorate, this column, if you actually see the dark line on this graph, okay, it represents the quality score of sentinel events. They actually studied how the sentinel event investigation is being done, what kind of information, what is the learning process they undergo during a sentinel event investigation. This particular hospital's average score, as you can see, as the years passed by, it has gone up high. And if you see the national average, the hospital was below the national average, and then at a period of time, they have actually increased their average score. So learning from sentinel event is just one of the main activities needed to improve patient safety. And the score we assign to the quality of sentinel analysis report is not a measure. But again, every hospital needs to focus incident reporting as a learning tool. So what is a good reporting system? Of course, tool to gather information from multiple providers to try to understand the factors that contribute to them, and so that it can prevent recurrences. Feedback and dissemination of information is very important to create awareness of problems that have been encountered, okay, and an expectation that errors should be fixed and safety is important. Finally, analysis of incident is where a lot of effort is being going, and such analysis of incidents can increase rare and common events reporting. Last but not the least, let me finish with 2 patient stories. This is how we can actually learn from incidents. So you can imagine a patient was angry in the waiting room, rejection of a registrar's order in the pharmacy. Patient was aggressive when the informed plan on change of antibiotic injections. And also the patient was angry and left without taking the 6th dose of antibiotics. So when the incident has come, it just came as patient was violent because patient was not ready to comply with hospital policies. But actually with investigations, why did the pharmacist reject the registrar's order? Why did the consultant plan for change in antibiotic made the patient angry? Or why was there any system gap in general not related per se to this incident? So what we learned, I do not have time, so I can't go in much in detail, but such kind of questions and inquiries we should go through instead of just blaming the patient that there was an issue with him. So there was a lot of gap in understanding to follow policies, or maybe there was a communication issue with the patient. How the physician talks to the patient is also important. And finally, there was some system gap. Another incident, albumin infusion of a discharged patient was found in the ward refrigerator. Okay, so what was when you see it, it looks like the nurse forgot to take the albumin. Well, there are a lot of other things which is also a contributory factors. On discharge of the patient, the staff nurse missed to check the fridge where the albumin infusion was stopped. Why? There was no opportunity to cross-verify the MAR and the return medication was not utilized. Current EMR does not support the pharmacist of the ward nurses to see whether the medication dispensed. So there was some issue with the system as well. An unused medication charge was not refunded to the patient. So there was a violation of patient rights as well. So such kind of education is what we're looking forward for. And thank you very much. Hope this session added value to all of your time. Thank you, the organizers, for giving me this opportunity.
Thank you. Thank you so much, ma'am. That was truly a very amazing presentation, and it was so enlightening with all the examples that you've given us. So the next speaker is our very own RISI member, Jancy Nirmala, madam. And madam, are you there?
Yes, ma'am. Yes, I'm there.
Okay, so welcome, ma'am. And today we have IPC and Patient Safety Coordinator in American Mission Hospital of Bahrain. She's going to talk to us about incidents reporting, barriers, and strategies especially to promote safety culture in the hospital. So over to you, madam.
Yes, ma'am. First, I would like to share my screen. 1 minute. So, as Rohita ma'am introduced me, I'm Jancy Nirmala, and I work as IPC and Patient Safety Coordinator at American Mission Hospital, Bahrain. So, today, and first, I would like to thank Dr. Tannarasu for giving me this opportunity to do this presentation. And I did my CPHQ in Rishi, and I learned a lot from him. Thank you, sir. And I'm able to implement that also at American Mission Hospital. Okay, now today is incident reporting, barriers and strategies to promote safety culture. The previous presentation, Dr. Aysha actually had covered almost all the topic about incident reporting, and it was very elaborate and very informative. Thank you, Dr. Aysha. I have something to add to it, and hopefully I have 30 minutes time, and I'll try to finish over that time. So these are my objectives today, so you can read on to it. This topic is very wide, and to cover all that in 1 hour or a half an hour time, it's really difficult. But I'll try my best to just cover at least the important topics in this incident management and how this safety culture matters when we have to establish a good reporting system in any organization. So it's very familiar. This error to human, this patient safety movement, impact of error to human is a very popular report that was released by IOM in 1999. And this was brought national attention in the problem of preventable medical error in US health system. And they had pointed out 4 important points, or the 4 important strategies, I could say, to improve the healthcare system. As you see, in this 2 of the topics is today's presentation. Okay, establish national focus and enhance knowledge base about safety. Encourage healthcare providers to participate in voluntary reporting systems. So that is one important topic which we are covering today. Raise expectations for improvement in safety. Improve culture and systems in healthcare organization for a safer healthcare delivery. So this is the second topic also being covered today. So among these 4 points, 2 points which is very important you see here is incident reporting and a safer health culture. That is very important. Next is, what is the role of organizational culture? So first let us talk about organizational culture, then we will move on to the incident reporting, barriers, and how we can overcome it. So organizational culture is shared assumptions learned by a group as they solve the problem that originate in internal and external environment. Norms and behaviors that are taught by leaders, it may be a designated leader or maybe a situational leader, that define how to think and feel about this problem. You can see here Shane 2010. Okay, something about this Dr. Edgar Henry Shane is a former professor at MIT Sloan School of Management, and he is the one who made this model of organizational culture. And he has got a lot of awards and he has written a lot of books on this organizational culture. So, role of a safety culture. 4 beliefs is present sense that about this safety culture. Our processes are designed to prevent failure. We are committed to detect and learn from errors. We have a just culture that discipline based on risk taking. People who work in teams make fewer errors. So these are the 4 beliefs in a strong safety culture. And role of a leadership when it comes, Joint Commissioners mentioned the essential role of the leadership in developing a safety culture. Leadership's first priority is to be accountable for the effective care while protecting the safety of patient, employee, and the visitor. Leadership commitment to creating and maintaining a culture of safety is just as critical as the resources devoted to financial stability, system integration, and productivity. This, in many hospitals, you will not see where leaders are so much focused on safety and culture. Because in any industry for that matter, there is a lot of finance going on, and especially to build a hospital and to invest on employees, invest on equipment. So all the mindset of today's leaders has mostly become as revenue. Mostly in the balance scorecard, the finance take a major role. But what the Joint Commission is talking about is how you treat the financial stability, system integration, and productivity. Same importance has to be also given in the culture of safety. Now, this is again Dr. Edgar Henry Shane's 3 levels of organizational culture. Okay, so 3 levels of organizational culture, the way we do things around here. Okay, observational behavior. Otherwise, in the books, when you read, it's called as artifacts, the behavior, which is seen and tangible. For instance, we have, say, organization A and B. Maybe organization A are very casual, how they speak, how they dress. So these are all you can visually see. Or the structure of the departments, the way how the chairs and tables are arranged, how it has been painted, how it is exteriorly shown. So this is about the exterior. And the staff behavior, like how they address, how they normally talk, their behavior. So which is tangible, which can be seen. And value is little hidden. And this is the belief of each and every employee of the organization, as well as the mission of the organization, how it has been. Here the mission plays a very important role, because if the staff of the organization have got this mission in their minds, the value system changes. So that has got a lot of impact on the culture or the safety culture of the organization. The third is the underlying assumptions. Okay, and the underlying assumptions is very, very strong, and it's unconscious and it is not shown. For instance, if you have a male dominant society, so the male in any form, maybe he may be a manager, or he may be a doctor, or he may be any admin staff or whatever it may be. So their aggressive behavior, if they're going to have, it is having that cultural, that is underlying assumption. This culture is very strong, okay? And this is unconscious and it is not shown. And it will also differ from region to region and organization to organization, okay? So for an example, if you see in this slide, so behavior. I told you the first one is the behavior, which we can see. Behavior consistent with belief, 50% agree, staff feel free to question decision or action of those with more authority. Okay, the behavior, I mean, if you see that safety culture report, it might say that this is their percentage, but originally the underlying assumptions may be differing, and then in reality, if you go and see at the ground level, whatever that percentage, maybe it's even more lesser than that. That's what Dr. Edgar is trying to say. And next is the belief and value. Communication openness belief. 79% staff agree. The staff will freely speak up if they see something that may be negatively affecting the patient care. So in reality, it may not be the same. So what are the underlying assumptions? Safety is a system property. So if you have what he's trying to say is that underlying assumption should be strong. Safety is a system property, that we should voice our concerns about the patient safety. If it is embedded even in the unconscious mind of a staff, then you will have the real behavior that is coming out as a behavior and belief and value. If this basement, this underlying assumption is not strong enough, then whatever you see outside maybe not coinciding with whatever the safety culture report results what you're getting. So that is what he's trying to say. So the culture, again, you see here in this, there are 4 categories of organizational culture, according to him. Macro culture, that is, as I told you, like in different country also, it is differing. Definitely the UK and USA, the developed countries, professionals' mindset is different from when it comes to the developing countries like India and other Asian countries. And next is the organizational culture. So now from macro level, we have to come to the organizational level culture. And next is the professional culture. Okay, the culture among the physicians or the nurses or the allied health. And apart from all this, the unit and department microculture. So this unit and department microculture has got a very, very important role. For instance, if you conduct a patient safety culture in your organization, and it is, if the culture results are low, it doesn't mean that it's the leadership has made a mistake or the quality department has made a mistake. If you, the important vital thing is you should compare among the departments, okay, the departments, because the establishing a culture of the organization, I understand it's top down, but it's not only the responsibility of the top people, it's the responsibility at the ground level also. So that's why I told you, according to this Edgar Schein model, the basic, the assumptions, the inner mindset of the employees should be also built. And so the unit managers, the supervisors, the charge nurses, all they also have a very good, big role in the unit department microculture. There are different kinds of four components of safety culture, as he says, like informed culture is there, flexible, learning, reporting, and just culture. So informed culture is safe, highly reliable organization, and flexible culture, the organization changes process and systems to improve team communication are optimized. There is psychological safety to speak up about the safety related to information. Psychological safety is a very big chapter by itself. Psychological safety is without fear. There are even tools to assess psychological safety in your own units or organization. You can assess and you can see like how much really they feel very free to talk. So psychological safety basically says that the staff, whatever they have, without any fear, they are supposed to, or they should be empowered to speak up to the managers or the supervisors. And if they feel inhibited, then there is something wrong with the manager or the supervisor or the leadership. So that is very important. And next is a learning. Information from reports is used to understand risk in the organization, how the systems and processes can be improved. Reporting culture, staff feel safe to freely report the errors and unsafe situation, and they understand how the information is used. Just culture, that is, there is a fair, transparent, consistent system of managing events, demonstrating a shared accountability between the system design and the behavioral choices. This is a scatter diagram, and you can see this hospital survey on patient safety. That is what is high HSOPs are about. Scores are associated with the fewer adverse events, which validates patient safety assessment as a meaningful indication of the safety of patients. So now let us come to what are the barriers and how we can overcome it, or what we can do to make the culture safer. So first one is the worry over the legal ramification. So definitely if there is an incident, SAC1 incident or the Sentinel event has occurred, really any healthcare worker would really threaten fear, because what will be the consequences? Like, no, it may be major, it may be minor, they might lose even their job. So all this will be running, okay? So there is something called as like open disclosure, and the open disclosure, if you really read, and you will understand what the management has to do for the patient as well as for the employees who are involved in that, and how it would benefit the organization. So when you have time, please do read on that. So legal reprisal over reported incident is common fear among the healthcare workers and staff. Staff to alleviate this fear by educating all the parties about what is done with the reported data. A standardized incident reporting form should be having the facts and should not raise concerns about how it might be used should legal action occur. So how do we promote that? What to include in the report? We have to give training. That is very, very important. How do we write an incident report? And what to include, what not to include, how to concentrate on facts, and how to handle second-hand information. How to frame the relevant details, avoiding opinions and blames. Like, no, The patient was upset, the patient was angry, the doctor was the doctor was not very happy. These kind of additional explanation on how the situation was to give our own opinions while writing a report is not necessary. And the blame, all that should be avoided. Just to mention the facts. And the bottom line is to let the staff know that if an investigation occurs, they are called to speak about the reported incident. Best incident course of action is to speak honestly and factually about what has occurred. And the second is blame and shame culture, guilt and fear of punishment. So historically, a culture of blame and shame and fear of reprisal, including job loss and loss of licenses, were seen as the biggest factor preventing staff from reporting the any incidents. So we have to promote the just culture. So what is just culture? The just culture program teaches hospital leadership to address safety concerns by offering a strategy so that the employees are not punished for decisions taken in good faith. So there is a just culture algorithm. It is a structured approach that encourages hospitals to look at the system factors instead of individual blame. It teaches an organization how to detect and manage disruptive and unprofessional behavior that puts patient at risk. Each manager has a just culture algorithm posted in their office also is being recommended. This is the algorithm based on decision making, how to manage behavior, human error, at risk and reckless. So shared accountability. What is shared accountability? Employees also have got a role to play and the system also has a role to play. So whatever has occurred, so we have to take decision on this basis of algorithm. First is human error. Inadvertently doing other than what is intended. It may be a slip and lapse and mistake. So in that case, we have to console the staff. For instance, by mistake, the staff is supposed to give an antibiotic, say 1 gram, and she gave 1.5 gram, or like, no, she has to give it to patient A, and by mistake, she has made some error. That is when we investigate, as Dr. Aysha talked about the decision tree. So when we investigate, we know like what was there, what was reason behind. So if it is a human error, we have to console. At risk behavior, like taking shortcuts, like if there is a bundle care that they're supposed to follow 5 steps before doing starting at central line, and if they're going to cut it short, so that is at risk behavior. They are taking risk. So in that case, we are supposed to coach them. And reckless behavior, choice to consciously disregard a substantial and unjustifiable risk, that is being drunk while at work. Yeah, so all these are the three algorithm that we are supposed to take, and then they're saying about to punish. Okay, now these are the training resources. So this is the site. If you want, you can go in and you can be qualified also. You can get certificate also on just culture. There is 3 days certification. There is 6-month certification. In your own pace, you can learn. And next is a lack of time to report. Imagine a typical nurse working a 12-hour shift, treating a patient in your facility. Depending on the unit or department and your geographical location, the nurse to patient ratio definitely differs. Especially in India, the patient ratio, nurse to patient ratio is very high. From 1:2, also to 1:6. How easy or difficult does your organization make it for the nurse to stop and report the crucial details of an incident while they are fresh? So that is very, very important. How do we promote? Giving staff time and tools they need to complete a report at the time of incident rather than at the end of their long shift is essential for promoting safety and compliance. But it also shows providers and staff that there is nothing more important than their perspective to help the organization learn. So we should understand how important, how it is going to, there is 2 ways of learning. One is learn from your own mistakes and learn from others' mistakes. The organization or an individual person, anyone who is learning from the other's mistake will definitely grow a lot. And that is the main purpose of this incident reporting, so that we can learn from others' mistakes, so that similar mistake cannot happen. So if we make them understand how important they are when they report, then definitely there can be a system change. And next is about no easy reporting system. Yeah, that is a big form you give them and there is a lot of information for them to write. Definitely they get frustrated. So today's incident management methods require more than tracking incidents or near incidents at the hospital bedside. So definitely now, because of this past 2 years being fully, the world is being frustrated with this COVID, not now the bedside, more than the bedside thing, there are a lot of other branches which is it's very, very active. and there also incidents can occur. As practitioner increasingly administer care and services in outpatient ambulatory or retail clinics and in specialty centers, but now the telemedicine is booming all over the world. Via even telemedicine, our safety and quality improvement tools must adapt over these areas also. In other words, we must follow the patient and provider to prevent the harm. So promotion, how do we promote it? As a result, it is best to use automated online forms. Okay, very vital information, which is immediately what we have to grasp from their mind immediately when they are fresh, when it is just fresh in their head. That we have to have that, see that is there all being captured in the form, and that allow the staff and the others to quickly report any near incident. Make the form easy to use and accessible by computer, tablets, or smartphone to increase participation and complaints and to capture details that could become lost as time passes. Next is no trust and follow-up, repeated reports with no follow-up. So let us return to our example of a nurse and imagine that he has taken time to report 2 separate incidents wherein he has first-hand knowledge. The first was the patient call and the second was the medication error. However, he does not hear back from the administration and has no idea about what was the action, if any, has been taken regarding the reports. So this not only applies to this follow-up, not only applies to our incident reporting, even for our patient safety culture, whatever survey what we are doing, there should be some amount of action. Otherwise, next time you go ask them to do something like, no, write an incident report, it won't have any value. They will say, whatever I wrote, like past 1 year, nothing had happened. And what is the use of writing again? So this would be the mindset of an employee. So what do we do that? The healthcare organization that fails to follow up on reported incidents or to communicate effectively about subsequent actions and resolution has failed in its duty to protect patients as well as staff and the organization from harm and liability. So in this, what we do is, like, we make it open for all our staff members, obvious, like what was the incident of that particular month or a year, and we tell them what actions were we taken, and we keep it like, no, though the names are anonymous, but what was the lesson learned is kept open for us, so open to all the employees of the organization, so that similar incident will not occur. Already reported the same event in the past. So this is also one mindset. Okay. Ultimately, a sound incident reporting system enables staff and the management to be synchronized regarding which improvements to prioritize once risks within the organization have been identified. Every staff member has become challenged to do things better or differently in their department once it's determined whether more times, money, people, or material should be made available to alleviate the risk. So we have taken some action first time that similar incident has occurred. Maybe similar incident can happen. So it doesn't mean that, like, no, last time I reported a fall and this action was taken and still the patient is still falling. What am I supposed to report? So that mindset should be removed. So maybe we have to have more investment done to prevent this similar incident to happen. So, but then that cannot happen where there is a failure to act amid patterns of repeated risk. Report of incident that repeat should be red flagged. That means what action prior we have taken is not adequate. That is a red flag. Staff should continue to report the same or similar incident can become demoralized, increasing the risk that they will not report in the future. So it's very important for the management to make them understand whatever action was being taken, it was not effective. Similar incident happening is a red flag, and how many other times it happens, you have to keep reporting until we have zero incident on the similar same problem. Details are lost with time. When near incidents and the staff response to incident are accurately captured, the costs are high for the individual practitioners as well as the healthcare system. This is very, very important. Risks include patient harm, regulatory non-compliance, malpractice, and poor public relations. Accurate documentation can make the difference in avoiding a missed improvement opportunity or failing to recognize and remedy any errors that has already occurred. So how do we promote that? Ensure that your organization protects the accuracy and the permanency of the incident information. Participants should be able to provide lengthy description in open-ended response box as well as respond using yes or no question. Include supporting details in the form of attachments such as photos, videos, or voice recording. See only relevant questions based on the incident type that is being reported. Remain anonymous if they choose, and if the policy allows. Now, last is the lack of encouragement from the administration and colleagues. Who is accountable for capitalizing on quality improvement and patient opportunities in their healthcare organization? Is it the leadership alone? Or is it the manager, or is the quality department, or is it the staff? So these are the normal questions. So who all are supposed to be involved in this? Actually, the culture as well as the incident reporting goes hand in hand. If there is a good culture, there is good reporting too. For organizations seeking to improve their reporting culture, there are 6 key groups and the areas that is to be considered. Okay, top management. Management must be visibly committed to the processes. Middle management must be actively involved in their programs. Supervisor performance is focused and linked to KPIs. Employees must be encouraged to actively participate. The reporting system must be flexible enough to accommodate the site or organizational culture, and the reporting system must be perceived as positive by the workforce in knowledge, and what is reported will be respected and acted upon, and that acted upon is very important. So as I told you in conclusion, an incident is just a tip of an iceberg, as Dr. Aysha told. A sign of a much larger problem is there below the surface. So the culture of safety is a journey and not a destination. It requires our continuous diligence. So as I told you, this goes hand in hand. So as quality professionals, let us improve our incident reporting by establishing a safety culture in our healthcare system and provide safer care to our patients. And thank you. If you have any questions, you can feel free to ask me.
Yes. Thank you, Jancy ma'am.
Thank you,
Thanks,
Thank you, sir, for giving me this
thanks a
opportunity.
lot for your thanks a lot for your presentation.
Yes, sir.
And my special thanks to Dr. Aysha ma'am also.
Thank you, Dr. so much.
I have some questions from Dr. Aysha presentation.
Okay.
Yes, Dr. Aysha ma'am.
Yes.
Yes. So, as per your presentation, which one is more, what is actually mandatory incident reporting? Sorry, internal report. Mandatory internal report.
Yes.
What does it mean actually? Whether incident reporting is mandatory?
See, so if you are being accredited by an organization like Joint Commission International, yes, it is mandatory.
As per JCA, incident reporting is mandatory?
Yes. You need to have a system where we can actually report errors and learn from errors.
No, the system is mandatory, or each and every employee should report. Which one is mandatory? Whether we need to establish system for reporting, or each and every employee need to report without fail. What do you think? I want to know what is exactly mandatory internal report.
What is exactly mandatory is had to have a system.
System.
Yes.
Okay. And regarding the reporting system, like electronic or paper, even if it is, we can use anonymous as well as confidential or open system also as per your presentation. But what is your recommendation? Which one is the best system for reporting culture? Which one we can recommend as a quality professional? Which one we can recommend to our people?
I would, like I told in the presentation, Doctor, I would recommend not anonymous. It should be confidential. Because anonymous, the problem is you cannot follow up, you cannot ask questions. But if it's confidential and the employee has a trust to the system, you cover up the names, but you can act, the quality people can only focus on the names and others does not have to know the names. That's how we implement.
But the recommendation from literature, from research literature, if you want to promote incident report, if you need more incident report, we should use anonymous reporting. This is the recommendation even from international organization, even from AHRQ. If you need more incident report, if you're going to promote incident reporting, this is more important, the reporting system, anonymous or confidential.
Yes, okay, maybe.
So if you compare both, yes, if you compare both, probably from anonymous, we can able to get more, correct?
You might get more, but it will, what I am seeing it as a whole picture. If you want to learn from incidents, you need to understand how it happened. You need to get more information. So if you don't know who reported, how do we follow up to get more information?
Mm-hmm. But if it is near miss, okay. For near miss, confidential, yes, we can use, because sometimes we can give rewards But for adverse and sentinel, if it is not anonymous, is it possible to get? Is it possible to establish reporting culture?
That is where culture comes in, doctor. So this is a very tricky balance. Now, see, there is advantages and disadvantages. Like you said, advantages, you might increase the number of reports, but if you cannot learn anything from it, you just have data and you have information.
No, ma'am, without sufficient data, how can we learn? As I mentioned,
I agree. Without
only from anonymous reporting, we can able to get more sample size. Statistically, I'm speaking. Yeah, without sufficient data, how can we learn from mistakes? We need more data, correct? Then only we can able to see the pattern.
Yeah, but doctor, is there a complete guarantee that if it is anonymous, you will increase it double the times if it's confidential? Than if it is confidential? I don't know. I'm just asking you because I feel the employees in an organization should build up a safety culture, and based on that, you promote confidential reporting will finally improve incident reporting. Like you said, anonymous might have a lot of reports. I agree.
If there is culture, if there is positive culture, yes, I agree with your point. We can go for confidential. But still, still there is no culture in, not only in India, everywhere, still there is no positive culture. So how can we recommend confidential? So what is an average positive culture worldwide regarding quality as well as patient safety? Less than 40%, the positive culture. Even as per AHRQ survey, benchmarking, worldwide, the positive score for less than 40%. So if it is less than 40%, how can we recommend confidential? This is my question. If there is culture, yes, suppose if you got more than 90% in your organization, people aware about patient safety. If there is support and commitment from our top management, yes, of course we can go for confidential. But without culture, without support from our top management, without awareness, how can we recommend confidential? This is my question. What do you think, Jancy ma'am?
Yes, sir. Actually, as I told on my presentation, the culture and the incident reporting goes hand in hand.
No, what is your recommendation? Because I'm not expert in patient safety. What is your recommendation for incident reporting system? Which one you will recommend, anonymous or confidential?
Sir, see, there are certain sensitive things like which staff do not want to reveal that, I was the one who reported. So these kind of incidents, for example, it may be about
not for some scenario. Anonymous.
I would say anonymous also is fine, and it's not that we will not learn or how to investigate. For instance, if we are going to say this person is coming all the time with some kind of having some kind of alcohol or something, he's coming for duty. If he's going to anonymously report, now who reported is not a problem. About whom is the complaint is the problem. So we have to really see what is the truth behind it. Is really he's coming with
exactly.
So not necessary every report we should know the information should be there who is actually the incident should have the names who are reported. Even if without names also we can find out where is really the problem.
Even for survey, not only for incident report, even for safety culture survey or patient satisfaction survey, no need to write the name, correct? This is not mandatory.
Yeah.
So, what do you think, Dr. Aysha ma'am? Suppose if you're going to conduct a survey about this problem, which one we can recommend? Whether we can recommend anonymous or confidential, for which one you will get support from your employees? Suppose if you're going to conduct a survey about this methodology.
I see both incident and survey reports differently. For example, the objective is different in my perspective. For example, when you do a survey, you're understanding the culture. For example, safety culture survey, we do anonymous. We don't want to know the names because even if one person in a unit has this particular understanding, it's the culture of the unit. But when it's an incident investigation, why I said confidential is it's more, it's workable in our organization. Maybe in different organizations, different things. If you don't know the exact data, because people don't write incident reports very clearly. There is also very lack of education or lack of understanding on how to report or what to report. Usually what happens, many of the incidents they report is very vague. if a quality professional looks into it and does not get the right information, maybe even the investigation or the actions can go in a wrong way. But if you don't know, if you cannot interview the staff who's reporting and find out more data, I feel we are wasting our time. When time is there, you need to have time to understand investigation. So to conserve time, to give value to everything what we are spending, I feel the name should be required for incident reporting. Again,
But
it's confidential.
is there any recommendation from JCA or from AHRQ for this confidential or what they are recommending?
JCI doctor, I am not aware of any recommendations as such what they recommend, but I have heard that many of the organizations, they would want confidential because of this particular issue. But anonymous for survey reports, I would say anonymous because we don't need to know how staff X or staff Y.
This is very clear because even I saw many research regarding this issue. But what is their recommendation for incident reporting system? Anonymous. There is no doubt.
Sir, may I add a line, sir?
Yeah, please, sir.
Sir, the submission of name should be mentioned optional. If the complainant wants to, yes, if the complainant wants to give his name, he should be allowed to give his name. Plus, it should be written underneath that your name will be kept confidential to the complaintee.
Yes.
So that it is not really revealed to the person whom against he has complained. This should be assured to him before that. It should be mentioned there. Your name will not be shown to the person concerned or against whom you are complaining to. So it should be mandatory.
But the doctor, actually, now the problem is from which method we can able to get more response?
Sir, by encouraging them, and giving them some prizes that such a department has given so many complaints. That means it is more than better than other which are not reported.
Okay.
Sir, it is reward and recognition.
Yes. And
sir, the entire course of thing is the culture of the safety is basically with the mindset of the organization, sir. As the madam said, the culture, the entire management should focus on they should give a free hand to the staff to ensure that anything which should not go unnoticed or unreported, sir, actually. So when when the management gives that kind of a confidence and the trust to the people, I think this culture will slowly but steadily will get ingrained into the staff's mind, and it will ensure that the safety culture has been imbibed in everyone's mind, and that way itself will ensure that reporting has been done as per the requirements, sir. That's what I say.
Exactly, sir.
Sir, if you make it mandatory to write the name, people will be hesitant to write the name. But if you make it optional, people will be encouraged to write it without them. And then maybe
this is my recommendation, sir. You know what is my recommendation for incident reporting? Better to use both anonymous as well as confidential. We can provide.
So my question is, sir.
Yes, please.
I have a question, sir. Sir, is there any which recommended incident reporting form, sir?
I don't know anything about NABH standards. I am sorry.
Okay,
I'm
sir.
totally away from NABH.
Okay, sir. It is the JCA any reporting.
But the recommendation from JCA is very clear, anonymous.
Report format.
Report
format is there, sir?
Yeah, reporting format is reporting format. Actually, still there is no standard reporting format, sir. Only we have guidelines from WHO. Am I correct, Dr. Aysha, ma'am? Still there is no standard. The tool. Still there is no standard tool for incident reporting. Correct. There is guideline from WHO, but there is no standard tool. Am I correct, Dr. Aysha, ma'am?
Yes, you're correct.
Yeah.
So there will be a variance from the reporting format from one.
So actually we adopted from the Australian because we went for Australian accreditation, and they are giving us, their website gives us all resources required, and they had given a template of the SAC 1, SAC 2, SAC 3 incident reporting with the contributing factor, and we adopted from there.
Excellent.
So it is available.
Ma'am, we would like you to share that also. Incident
please try to share in our group.
I will share it in the group.
Yeah, sure. Thank you, ma'am.
Thank you so much.
And yes, Dr. Aysha, ma'am, is there any significant difference between risk matrix and the SOC score? Yes, SOC score and the risk matrix. Is it similar things, or is there any difference between risk matrix and the safety assessment? Is there any significant difference between risk matrix? You know, risk matrix?
Yeah.
So is there any difference between the risk matrix and the safety assessment score? Because as per your presentations, there are 3 levels of severity and 3 levels of probability as per SCAC score. But
Yeah,
I
it's
want to know,
almost,
is there any difference between risk? Because as per CPHM recommendation, now we need to focus on, now we need to use risk matrix. This is like,
actually,
you
there is
know,
only slight modification, not much difference between both. Because I feel in the risk matrix, you have catastrophic, moderate, and insignificant or something like that. And probability is always rare, possible, almost certain. And here you have different wordings. And you have 4
Okay.
scores instead of 3. So the minor
Okay.
changes are there. Yeah.
Okay. And yes, ma'am. And what about risk RCA analysis, root cause analysis and investigation? Both are different, or RCA comes under investigation? Because as per your presentation, I saw RCA root cause under investigation.
No, I just pressed on in RCA separate slide. It doesn't mean it's different. It's also a type of investigation. It's just that RCA root cause analysis, you do an investigation to find out root causes for sentinel events. And some organization use RCA even for near misses. Like for our organization, we use RCA even for near misses.
No. My question is actually whether we need to do investigation before going to RCA, or under investigation itself, we need to conduct RCA.
No. First, you need to do an investigation. First, you need to do an investigation to collect data.
Okay. So the next step is RCA, correct?
Yes.
Okay. And regarding incident reporting, which one is more important, ma'am? Action is more important, or data collection, or data analysis? For which one is we need to give more importance as a patient safety officer? Whether we need to give more importance for data collection or analysis or action?
Of course, if you want to improve reporting, you have to take actions for it. Action and feedback should be taken. But without collecting data and analysis, how do we reach there? So I think each step is important in its own way.
Okay, but just I want to know roughly what are the tools we can use for, especially for incident reporting analysis? Is there any standard from international organizations or some other source? What are the tools we can use, especially to do incident report analysis? Because incident report, we can able to collect many data, near miss, adverse event, sentinel, no harm, even non-OVR. Excellent. So this is the best source for data. So what are the tools we can use to analyze our incident report data?
We can use a lot of tools like pie chart or fishbone. These kind of tools will help you to identify.
Okay, good. So what is your final message to our people regarding your lessons, regarding your practice? So what is your message to all regarding incident reporting system and learning from this?
Yeah,
I
think the only message what I would want to see is like it's related to my colleagues, Jancy ma'am's presentation. It all starts with culture. We might have the best. It starts with culture. We might have the best robust system, and we might have the best team to do a statistical analysis. We might have the best, the team to work on. But unless there's a culture to report, it is very difficult to even compete with the best system you have. But yes, culture is not, it's not something which we can attain in a day. It's a slow progress, but have good faith and continuously educate and train people to understand the importance. And I think feedback and learning from incidents should start even from the board. I think the most important people who should first understand the importance of incident reporting is our top management.
Yes, exactly.
They don't consider this as important, or if they don't see value in this, then it will not drill down even to our nurses or doctors or anybody below. So I think it
should be from top down.
Yeah, it should be from top down. And even from the board level, not even just the CEO, even from the board level, they should also feel the importance of it, and also the near misses. Again, people do not value near miss. They see it
Yes.
as very less valuable. So this awareness needs high level. I mean, people should actually talk about near misses, which is not happening.
Exactly. Yes. Okay. So thanks a lot for your presentations. Personally, I learned a lot of things from your presentations.
Ma'am, I got one thing. What is OVR, ma'am?
Occurrence various reporting. Occurrence variance reporting.
Report. OVR.
Oh.
Yes.
Oh, thank you, ma'am.
Actually, I learned this from Dr. Tanarasu. We had our class, so he was stressing on it. So that was a new education for me also.
That is a new colleague for me. This was.
Thank you, Dr. Aysha, ma'am. Thanks a lot for your presentation. Yes. Jancy, ma'am. Jancy, ma'am. Statistically, I want to know which one is the main cause for reporting culture. Why still there is no awareness, there is no reporting culture in healthcare organization. So I want to know which one is the main cause. Is it because of lack of motivation or various
fear? Yeah, because historically or culturally, we were actually we were punished, like down the line, few decades back, we were punished. So that's still there deep in our culture, like how Dr. Edgar said, that is the base. So that has to come out, means it might take some more years too.
So for example, what is my dependent variable? Reporting culture. This is my dependent variable. And I have 3 independent variable. One is barriers, fear. And the next one is motivation. Now tell me, which one is more significant to reporting culture? All are significant to reporting culture, and are only motivation or fear or list of some barriers. Which one is more significant to reporting culture? Because I want to know which one is I need to focus.
Fear.
Motivation, sir.
Is there any research for this issue, Jancy ma'am? Whether you saw any research?
I haven't read. I mean, I have multiple. I can't remember. But what in our organization, what we have is like initially what we had was the feel of embarrassment, like that embarrassing situation. Like and we will be in limelight at least for a few days. So in a bad manner. So that embarrassing. I can't say like fear, but it's embarrassing. That that person gave wrong medication, like that whole hospital, it will go as a bus because it's a small organization. So that kind of a fear was more. And this fear, when it got was nullified, was like when it was just taken casually by the management and leadership, and when they did not make big issue out of it, actually that fear went off. And then now slowly they don't mind. Yeah, we made a mistake, we will learn from it. That mindset slowly they have, but it took a lot of years.
Even still there is fear from experienced person, even from physicians.
No. Now even physicians also fear, sir. Even physicians feel embarrassed, but the new ones who join our organization still have that fear. By seeing that old ones are old doctors are not having that much fear, they're learning from them. But when they newly join, I could see that fear, because they're newly joined, whether their contract will be renewed, whether they will be kept in job. This is not like India, where you have a government set up, you are there and whatever happens, nothing happens to your job. It's not that kind, isn't it? In a foreign world, anything can happen. So that fear, when they come as new, it is there. But over a period of time, they come over it. At least it takes 1 to 2 years for them to come out of that fear. They learn from us.
Whether you conduct any study or research for this issue, because as a patient safety officer, as a nurse, as a quality person, if you're going to build positive reporting culture, first we need to know the cause. Correct. What is the significant factor for reporting culture? Which one is we need to focus? Without assessing this factor, how can we promote reporting culture? Correct?
Yeah.
What do you think? What do you think about this kind of research? Is it more important?
Yes, sir. That actually we used this IHI patient safety survey tool only. Still, we are in the process of analyzing. So what we did was we asked year of experience at American Mission Hospital, and we are trying to differentiate the culture rating, like no, particularly the questions when it comes to this reporting, I feel confident enough to report.
Whether you conduct any study about healthcare workers' perception about our incident reporting
patient
system?
safety survey only we have done, sir, which has got a question on about incident reporting. Still, we are in the process of analyzing. There we added this question like, no, how much, I mean, how old are you in the organization? So this question and how confident they are to answer, like how they are open to answer. So this we are trying to compare. Still, analysis is not over. So only this year we did. We started to do this from March and April, and still we are in the process of analyzing and creating report.
Okay.
That definitely once I do, I'll share it with you.
Sure, ma'am. Sure. What about Dr. Aysha, ma'am? What is your recommendation for this scenario? Which one is more significant to reporting culture as per your organization practice? What do you think? Which one is more significant? Motivation or fear or some kind of various? Dr.
Mix
Aysha,
of fear. Yeah. Hello. It's a mix of fear and motivation, doctor.
But yes, ma'am.
Though there is no punitive actions taken without any justifiable action, but yet people just feel fear of maybe just being negatively viewed is enough for them, not even actually being punished.
Correct.
Yeah,
correct. Even negatively viewed, embarrassment.
Yeah, this was the result in 2010, but in 2022, which one is more significant to reporting culture? Motivation. This is the finding from a recent research article.
So may I add a line, sir?
Yeah, please.
So I feel that motivating factor and the fear, these are two important things. By removing the fear, by encouraging people to complain and giving them some prize, that this complaint has resulted in so much improvement. So if you give them prize instead of any punishable action, this will help to motivate other persons also, and this will remove the fear also. So adding a prize to the person and to the department by those who show more of complaints, this will help us, I feel.
Yes, exactly.
But can I add one more point, doctor?
Yes, please, sir. Please go ahead.
Yeah, actually, as per their latest one of the judgment in US, as reported by IHI, there is a non-criminalization of the medical error reporting. And recently, I have read an article from IHI saying that all the medical error reporting should be non-criminal nature, and it should not be taken into any of the criminal acts.
Criminal activity. Yeah. This is good. Yeah. So even we need support from our ministry. For culture, we cannot blame only our organization leaders or quality people, or even we need support from our ministry. Yes.
So this covers under the mistakes done with the doctors also, sir.
Which one, sir?
The incident reporting, all the things, sir, is in the clinical clinicians. They make mistakes which results in maybe near misses or sentinel events. Also, it can cause without even the picture coming into the nursing professions also. So this also has to be covered, no, sir?
Yes. This is the common practice. This is applicable for all, not only for nurses or physicians, for all.
Okay, sir.
Yes. Any other questions from others, please? 2 more minutes, please. Any other questions? Any comments?
So this is a very nice session, sir. Actually, it is a very lot of learning session. It will be useful for us if it can be sent to the presentation, sir.
Sure, sir.
Sir, during our residency days, we used to sit in the coffee house with a senior person, one senior resident and 2 junior residents. They used to discuss the operation theater problems. What a junior resident felt the problem, the senior resident who used to observe him during the operation tells them about the mistakes what he had done and how to improve upon them. So this used to help the other person sitting next chair also, so that in
Exactly.
his time he will not do such a mistake. In fact,
Yes.
all these amendments, all this guidance was only verbal. There was no documentation of this. So had it been the
Yes.
documented earlier, it would have resulted in further improvement. Now this
Exactly.
documentation and the formation of this form to fill up the complaint, it is very useful. If
Yes.
this is practiced, this will be much better. If this culture is developed, this will be great, useful to you.
Yes, sir.
Thank you.
Yes.
Sir,
Thank you, doctor.
is it possible to share the full recording of the session
Yeah.
to
We'll
all
share,
the
sir.
participants so that
Sure,
it will be a good record
Sure.
for revision of many of the things which we need to study more. Thank you.
Sure, sir. Definitely. Even we'll do more webinar from incident reporting, how to collect data and what are the tools we can use to analyze our incident report data, how to prepare action plan, which ones we need to focus. Simply we cannot recommend some actions to improve some process, correct? So we need to know which one comes under weaker action and which one comes under stronger action, correct? So there is some recommendations from JCI as well as from AHRQ. So probably we'll see in future. Thank you all. Yes.
Okay, sir.
Thanks, Dr. Aysha ma'am and Jancy ma'am. Thank you all. Good night.